often work days or vacations. Um, so excited to have everyone here. This is our week. We're focusing on cultural humility and collaboration, and we have a lovely webinar presented by a regular of ours, Dr. Jody Waldron. And since he didn't send me a bio, that's the joke that we've been making. We're going to crowdsource a little introduction because some of us know Jody quite well, but Jody is besides being a palliative care physician, he's the director or the medical director of the outpatient palliative care service at Harborview Medical Center, and also a medical director for the Cultural Mediator Program and Community House Call Program at Harborview Medical Center as well, which I'm sure he will talk about a bit here. Jody has done international work in palliative care, including in Navash, Kenya. I met Jody doing some palliative care collaboration work in Cambodia and eating tarantulas together, which I think is the thing that I included in my introduction last year. Dan, is there anything that we should add, like a good tidbit? Keep
About
appropriate for the group.
12 years ago, I had an injury, and Jody reintroduced me to fly fishing. And then, much to the chagrin of my wife, it has become a lifelong obsession. So I blame him for that.
So, Jody Waldron, responsible for your next hobby. Congratulations.
Absolutely. Great. I think
well,
that
Jody,
checks all the boxes.
I was going to say, I'll let you add anything else you want. And
Nothing
I will
to add.
happily watch the chat. And thanks, Helene, for recording.
Great. And I'll say, please don't be shy. And Michael, I'm terrible at chat monitoring, so feel free to just chime in on audio. And everybody, real-time questions, totally fine. I tend to blab a lot, so I wouldn't wait till the end if you got a question, because we might run over time or close to. Yeah, don't be shy. If there's anything I say that doesn't sit right or seems kind of, like it deserves some kind of rethinking, please let me know, because this is all a work in progress. So let me see if I can share screen, choose this one, and then do that. All right, I think that looks like it's working. Basically, my hope is, you guys are here for a reason. So my suspicion is you're already kind of keenly aware of how important kind of developing skills in kind of cross-cultural palliative care cases and engagement. But I'll try to convince you why it's important. We'll talk about one sticky case in particular that I had at Harborview that I feel like hits some of the common themes that you'll come across. And we'll talk about how to engage with that, and also kind of how to engage in some other ways, not necessarily on the level of the palliative care consultation, but kind of community engagement. So we'll talk a little bit about that, and if we got some time, we'll chat together and get some additional questions answered. And I can advance my slides. Okay, so I designed this slide originally as being fairly Seattle centric, and kind of talking about kind of immigrant and refugee populations in Seattle, but obviously this is a growing population in our nationwide community. So about almost 15% a few years ago of the population in the U.S. was foreign born. And if you included their children, it would be almost a quarter of the population. So, first and second generation kind of immigrant and refugee communities are more than 1 in 4. So, regardless of where you practice, there are growing communities that are either non-English speaking or coming from different cultural backgrounds. So it is the fabric of our country, and likely will represent the communities that you work with palliative care wise. What we know from the research, unfortunately, is that underserved communities as a whole are less likely to utilize palliative care and less likely to utilize hospice. And that can be related to healthcare access in general. That can be related to kind of communication challenges around how these resources are presented. It can also be a result of cultural norms that maybe these services, both palliative care and hospice, aren't geared towards certain populations or are not designed with those things in mind. And so I think all of those things are a little true. And the need for palliative care is not only in immigrant and refugee populations in the U.S., but really worldwide. We're doing a pretty terrible job at kind of taking care of people through end of life. And statistically, we only meet about 14% of the world's palliative care needs. So maybe some of the skills that you learn in the course of your practice can be applied elsewhere in serving immigrant and refugee populations upstream in their communities globally. So global palliative care is a really huge need. So the other reason that I think that this is really important to talk about is that these cases, from my personal experience, are amongst the hardest that I deal with kind of on my week in service at Harborview or in my kind of clinic population in the oncology clinic, et cetera. The cases that are where I'm coming from a cultural background and my patient and their family are coming from a cultural background, and the medical system has its own kind of mores. The conflict that comes about from those ingredients can be really hard. And I just want to acknowledge that it is hard for people who are extremely well-intentioned, hard for people who are kind and loving and pride themselves on communication. So these cases still remain fraught. Here I'm, approaching 10 years out of fellowship, and it's still hard stuff. So I think it's worth thinking about and working on kind of ongoing. The other thing is when these cases are hard, they can bring a certain amount of moral distress. And what we know from COVID and other kind of studies engaging with moral distress is that shortens careers. And so there's additional reasons to be thoughtful about how we approach these cases just from a sustainability standpoint. So that's kind of why I think that this is important. And so now a little bit more about what the heck I'm talking about. So when I say culture or cross-cultural, there should be a big asterisk there. I want to make a distinction in my mind between what I am trying to do when I give this talk and talk about various kind of cultural groups or ethnic groups or kind of even racial groups, is that I'm talking from a generalization standpoint, and that is my hope, and that generalization allows me to kind of make conclusions and make changes and actions for the benefit of a community, makes things kind of actionable. In contrast to stereotyping, where kind of a negative connotation associated with that group kind of pigeonholes them and has no benefit to them, and quite the contrary. So some of what I say, I acknowledge that I'm generalizing and may not apply to many members of that community, but it's in the interest of support and kind of accommodation, as opposed to stereotyping, which I hope I'm not doing. I also want to acknowledge that, while I am mindful or I have my mind keen to how communities, the patterns in a community, and how I can engage with a person better based on patterns that I know about or recognize, that doesn't always apply to the person who's sitting in front of me. And as we all know, in palliative care, the individual, we tend to bestow a lot of power on the individual, and they may not kind of fit in line with that community per se. And so the individual is always free to be different, and families are always free to be different from the cultural group that we presume they belong to, or that they belong to. I also want to mention intersectionality, and that there will be lots of components of the patients that you meet, and they will be disenfranchised for multiple reasons, not only kind of language barriers or troubles, cultural history or ethnicity, sexual orientation, kind of financial discrimination or kind of economic discrimination. So all of these things are kind of part of the package, and kind of acknowledging that there may be multiple reasons why this person is disenfranchised and why this interaction may be fraught. I think if this is still part of your guys' material that you're reading in preparation for your certificate, I wanted to kind of highlight when I was a fellow, kind of we were still very much in a cultural competency was the language of the day. And I was like, I am going to be an expert in this person's culture. But I think we've figured out that it's really about humility, acknowledging kind of privilege that we have or bring to the table, and kind of being curious and having humility as opposed to competence. So it should include this, lifelong, essentially, reflection of how am I doing about this? How can I reach these people better? And kind of recognizing that when you are in a position of power, which you will be in your healthcare setting 100% of the time compared to the patient who's sitting across from you, how can I mitigate these power imbalances? And then kind of in the interest of additional advocacy, is there change within my institution that I can affect that will kind of improve access and improve care and hopefully outcomes? So having that kind of ambition, I think, is also part of this. So I am going to mention a case that I took care of when I was newly out of fellowship. And it was a 63-year-old woman who was Somali, living with her family, and she had kind of progressive decline. Oh, one thing I'll say is that I am an internal medicine doctor and a palliative care doctor, and forgive me if I skew a little heavy on the medical details. I'll try to kind of keep it pertinent. But that's kind of, that's the baggage I come to the table with. But let me know if I need to clarify anything. So she had kind of multiple deficits related to kind of theoretically benign brain tumor, but was so big that it was causing lots of problems, or she had multiple of them. So she got admitted to the hospital. She had surgery, and it was very, very complicated afterwards, such that she had kind of ongoing seizures and respiratory failure and was essentially in like a comatose state. And then she developed an infection in this kind of surgical site while she was still in the ICU. And the surgeons were like, we can't cure this infection with antibiotics. She needs surgery in order to completely treat it. And the family said, no, we don't want to go through surgery because you just did surgery and look how terrible she looks. So they were not consenting to surgery. And so she kind of stayed on the ICU service for some weeks, and they consulted us for essentially goals of care. And she remained unresponsive. So and on a ventilator, and I had a trach at that point too. So she is at least on the order of some months after her surgery, and she was in a pretty dire circumstance. So they called us for a consultation of goals of care. So if this is the case that you get when someone's calling you for your consult, I try to institute in my daily life the practice of, when I get a call like this, it's a little triggering. I have to acknowledge, because I've had experiences in cases that have similar themes, they all kind of come up in my mind. And I don't know if PTSD is exactly the appropriate word, but I'm triggered at the very least by kind of cases that I worry will be challenging. And so when I get a consult like this, I have to immediately tell myself, like, stop, check in with myself, kind of, and how am I feeling about this, and just be careful that my prejudice, informed entirely by other cases, isn't kind of coming to bear on my reaction to this case. So, I don't know, kind of based on the case that I mentioned, do folks have cases that hit some of these themes? Have you kind of in the course of your kind of lives, either in your kind of your specialty, have you had cases where it's kind of fraught like this, where there's like a cross-cultural kind of concern and a kind of a concerning prognosis? And does this ring any bells for people? Okay, I'm seeing some nods. Good. Okay. In that case, stay tuned. Hopefully I'll make this kind of helpful. So again, I just want to reflect on and have that built into that receiving the first call. Kind of check in with yourself how you're doing. So the first tool that I will talk about is, tools and background to own your own bias. I think we're all kind of steeped in language that kind of we are all prejudiced. We are all have kind of tendencies to kind of racially stratify our decision making and all sorts of things that we're only beginning to understand. But I'll talk explicitly about biases kind of in palliative care specifically, and kind of healthcare in general. So it's critically important. So here's our kind of Norman Rockwell picture that depicts this, like, soon to be nuclear family of the 50s and 60s, and this quote that the American middle class is future-oriented, individualistic, bent on mastering nature, and concerned with doing. Okay, not content to kind of sit and let things happen. They've got to be actively managing things. This comes from a sociological kind of text from the 60s, and I think that if you kind of, with a little bit of squinting, you can kind of look at this quote and start to see where some of the kind of cornerstone values of palliative care and a palliative care assessment, where they're starting to come from. Okay, so this individualistic kind of want to be actively managed, or want active management rather than kind of the natural course of things. These cornerstones of patient autonomy, truth telling, kind of telling the patient everything and then making a shared decision, and then offering people control over this dying process. I.e., where would you like to be? What would you like your care to be? What kind of music would you like to have? These things, to that degree, is coming from this sociological phenomenon, which is pretty culture specific, which I will show. Okay, so the point that I'm stressing is that these things that we take almost for granted as like universal, that everyone should kind of want this, are fairly cultural specific, or culture specific. So I will try to prove that theory to you now with this graph. So this graph is kind of a visual depiction of several studies kind of cited here from the early 2000s, looking at several very broad categories. Okay, so not to say that there isn't a lot of nuance within these individual categories, but again, a pretty broad generalization. But again, in the interest of making a point. So as you can see, the European American kind of group down at the bottom, okay, believe in advanced directives. Yes, so that's kind of and having kind of autonomy. And these are studies of these groups. In terms of patient autonomy, is the individual kind of prioritized, or is it more the family? In terms of decision making, is it kind of an individual's role to make the decision, or is this something in times of illness that the family steps in and makes decisions on behalf of this person? Is it really important that bad news be broken to the patient themselves, and this truth telling? And then in the dying process, is it something that people want control over, or is it something where it's kind of felt to be a kind of a natural thing that happens when it happens? And so I hope you can see that these kind of line up 100% with kind of European American values. And again, big generalizations here, but the themes that we kind of rehearse in palliative care are fairly specific. And all these X's that fall outside of these purple lines are times where we might need a little more nuance and may need a little bit of a different or more culturally specific approach. So, you know, I joke that if we have all this information, can't we just make an app? And you can just like program in someone's like, you know, their cultural heritage, and it says does not like truth telling, like do not do this. And it's like I can't quite do that, because we all know that people are different in even within their cultural group, but it would be nice. So so anyway, this is to highlight the point that we're all coming with a certain degree of structural you know, prejudice. So looking at some other communities that may not be as well served by the system at hand. So kind of Asian American communities, again, broad generalization, more family oriented decision making, or, you know, so a study of Korean families, 72% felt like we shouldn't go to the patient when they're sick to be asking them about life support decisions. That's something that would be like most families would say, no, that's our job. That's not the individual's job. So in terms of Latino families, about 46% would, you know, feel that kind of yielding that decision to an authority like a doctor who might have more different experience, that might feel like a little more appropriate than kind of having the individual decide for themselves. And so I also want to explicitly highlight kind of our Native American communities. Again, very broad label there, but you know, the group least likely to be represented by the system in place, i.e., you know, belief in advance directives, not so much. And this was so much so that when there was a mandate to ask about advance directives when people are admitted to the hospital, and that's still a mandate, there was a lot of kind of question about and kind of discomfort from some Native American communities, where they're like, this is like culturally not a healing thing to do, to kind of ask about this kind of in this space and invoke this. So it was, you know, so in terms of that, in terms of like the family as a deciding unit or having control over this process, you know, the Native American communities, I think extra thoughtfulness and extra listening will serve you maybe better than kind of a standard approach. And this was kind of the study where it was kind of talked about where discussing advanced directives might be received poorly. And this is, again, not to discourage you know, advanced directives, et cetera. That's not my overall thought, but just that the way things are, it's worth it to tread carefully and with great humility. So when I say, oh, my bias, the bias I've been talking about is this kind of Western bias that we have in healthcare in general, but in palliative care pretty heavily. So be mindful of that baggage that a lot of us carry. So the other bias that I want to be explicit about is that we're all in the healthcare field. And what we know from studies is that by that fact alone, we don't represent the patient populations that we take care of. So if you reached out to young doctors and said, if you had a terminal cancer, would you want CPR? About 90% of them would say, no, I do not want that. However, if you go into a population in the community getting radiation for cancer, only about 6% of them would be DNR. And in the ICU at any one time, about 10% of them would be DNR. So we're talking about 90% of doctors wouldn't want it, but only 6 or 10% of patients. And so that's a pretty big kind of discrepancy. And it's just an important thing. I mean, and you might say that, oh, we're the most informed because we see how kind of terrible and brutal it is. But also just acknowledge that that's a bias that we're coming to the table with that doesn't apply to our patients universally. Okay, I think the other thing that was a notion that was hard for me to get rid of because I'd carried it around for so long, is that as someone who's, you know, has the palliative care stamp of approval, like you should be able to use language to convince anyone to do the right thing. Okay, you're kind of supposedly have that silver tongue that allows you to say things in ways that people just kind of do the right thing and do what you're kind of suggesting. And I feel like that is the hope a lot of times with the palliative care consult, where people will be like, "Hey, can you like say B, D, and R a little better than we can, so that maybe someone will do it?" And I kind of bought into that for a long time in med school and residency, where I was like, it's just a question of like being nice and skilled with language. And that's just not the case. Okay, really, our job and our charge is to assess people's values, be sure they're informed, assess their values, and kind of tailor the care to fit their values. And so there's no kind of like putting a big bow on your values and selling it to someone. That's kind of that's not really what the mission is. And and I'm a nice guy, and I can talk circles around folks, I guess, but at the end of the day, when you do that, it just doesn't, it's not durable. And when kind of the crisis moment hits, those decisions that are made just because you were said something nice, they don't stick. What has to happen is it has to line up with values. So be careful anytime that you're feeling like, the consult question is to kind of advertise what the team wants better. So I think you guys get a lot of the Vital Talk kind of language and acronyms, but really the goal is alignment, not advertising. And so you kind of learn about your patients, you work together to achieve that understanding, and then you kind of make the plan kind of fit both of those things. So the other thing that I want to mention is that this is the nature of our system, and I'm not I'm eyes wide open about that. And I had a Kenyan patient who asked me, when I was taking care of her at UW, who asked me, she's like, "Doc, why is it when I come to the hospital, doesn't matter why I come, when I get admitted to the hospital, they ask me, do you have a will?" Okay, and this was that federal mandate that says you have to ask for advance directives anytime anybody is admitted to the hospital. Why do you ask for a will? Like, that's terrible. Like what kind of message are you sending? You're just like, are you trying to help me get better, or are you just going to help kill me? Like, and so it was not the first patient of mine to say, like, this is very weird to me. And I think it's okay to say, like, this is why we do this. It's okay to say, like, the healthcare system is kind of geared towards people who want a lot of control, and they want to sit on the driver's seat. It's like, the Americans, they just want to have control over everything. And so they just like, that's why it kind of affords people a chance to make decisions and have control where they want. And that's kind of the intention there. And you can let people know kind of about the system and about the intention. And that that your job is really to kind of learn what they would want, and hopefully they'll forgive you for the trespasses along the way. Okay, that making sense? All right, so that was that first tool, owning your multiple biases, our intersectionality of biases. The second thing is to do a little bit of homework if you can. I highlight Ethnomed, which is a program kind of born out of Harborview, and as a kind of clearinghouse for information related to taking good care of immigrant and refugee populations, regardless of your specialty or your background. And it has all sorts of stuff: nutrition, diabetes, kind of OBGYN, kind of refugee, kind of struggles. So it's a good place to go when you're like, oh, I'm taking care of a patient today from a place that I'm not familiar with. I'm going to kind of learn how that interfaces with the healthcare system, and maybe get a little bit of background information. So I really like it for that reason. It also includes some basics on greetings. It includes some kind of primers and use of interpreters. as well as specifically some end of life practices among various groups and how that kind of, you know, how that may come to bear in like a transition to comfort care in the ICU situation or something along those lines. So might be burial practices or other kind of rituals. So it can inform a lot of that. And I think it's just a really great resource that I'm proud comes from Harborview. So I would encourage you to kind of poke around there. And kind of another part of doing homework or kind of being prepared is to kind of pre-meet. Okay, when you have an opportunity to work with an interpreter or a cultural mediator, to kind of ask ahead of time. It's really kind to let these folks know what you're going to be talking about. Okay, because working with the interpreters and cultural mediators, it's amazing how frequently they just go in cold with an OB-GYN or gyn-onc provider, and all of a sudden they're talking about this person having metastatic terminal cancer, and they have no idea that that's about to happen. And so preparing them for that is really professionally important, and so that's part of the pre-meet. I think that, if you can get information about are there, certain things that might be taboo, whether that's use of the word cancer, use of the HIV, TB, various things. If there are patterns in terms of like family decision making versus individual decision making, you might get some of that information from an interpreter, but specifically a cultural mediator as well. Are there patterns of nonverbal communication, like heavy sustained eye contact might be kind of less friendly and kind of more confrontational than you're intending, or physical contact might be more kind of inappropriate than you're intending. So some of that social graces, like crossing your legs and showing the bottom of your shoes, like might be kind of perceived of as kind of unintended disrespect. If there's any of that information that you can gather ahead of time, it's nice to try. And the intention is not that you become this ambassador to this community and that you are an authority now, because I think that can be really obnoxious. I think the idea is that you demonstrate that you're interested and that you care. It's not that you become an authority. Okay, so when I had this consult, kind of going back to our case, what the team had called me about, they were just like, they just don't get it. Now, you guys will hear this language all the time. They just don't get it. You need to they just don't understand. She's not going to wake up. Okay, she's in a coma, and they just want to keep doing what we're doing, but she's not going to wake up. There was a component of disrespect where the family was particularly hard on, some members of the team, and kind of more deferential to other members of the team, and that was promoting some hard feelings on the team. One of the surgery attendings was just like, well, we told them what they should do as the standard of care, and they've refused. So we should just discharge them home. They're not doing kind of what we want. So like, how can we discharge them home? And then also the financial concerns, not that I have any idea what I do costs anyone ever. I have no idea. I know that our healthcare climate is one of a lot of expenses that we probably can't afford, but I feel like this little, how much is all this going to cost? It's like, it is theoretically important in the kind of macroeconomic macro scale, but I think on the level of the case, it tends to speak more to like moral distress, maybe more so than actual financial concerns. But you'll hear this a lot. How much is this all going to cost? Like just keeping her alive like this. So that, I think all of these things kind of speak to or are kind of our manifestations of moral distress, or kind of trigger moral distress. So I think that this is an important part of palliative care's role in the healthcare community. as well as in these cases in particular, is like sniffing out this moral distress and trying to, air it out a little bit and support people with it and through it, for lots of reasons. One is it leads to burnout. Okay. And like during COVID, I think we were all kind of acutely aware of how these stresses just chewed through people and left people shells of their former selves. So it leads to kind of higher staff turnover. It's expensive for institutions because they got to train people all over the place, and people just don't stay in their jobs, and it's pretty brutal. So I do think having an eye towards this to help with it is important. The other thing that moral distress does is you know, it's totally it's counterproductive, in that it's coming from a good place. I see lots of times, say for example, an ICU nurse taking care of someone that they feel like, gosh, this wouldn't represent quality of life for me, and I'm prolonging this kind of poor quality of life from my perspective. And so they carry that moral distress, and how it manifests is in body language. They're a little more short, they're a little less open. They might even push the conversation a little bit. So there are lots of ways that it is apparent to families, and families are keenly aware of our body language in these cases, and kind of any tone that is out there, whether it's intentional or not, the family is going to pick up on, and they might misinterpret that distress is not coming from a place of love and caring and sympathy, but is actually coming from a place of not caring. So it's a really high risk of kind of having the exact wrong impact, where what you're doing out of caring kind of is misinterpreted as carelessness or kind of callousness. And so I do see that a lot, and it promotes a lot of distress or a lot of conflict between families and nurses, particularly. So one of those reasons to kind of keep tabs on your own kind of moral temperature, your moral distress temperature. And if you see it around you, kind of engage with it. So the other manifestation is we'll get a call on a Tuesday, and they'll be like, "Hey, we had a goals of care conversation yesterday, and they're still full code and still longevity focused measures. Like, can we have another family meeting on Friday to just to kind of check in again and do this again?" And I think a lot of times that has kind of a counterproductive effect too, where families are just like, "We just did this, we just talked with you about this, and now you want me to do it again? Like, are you listening? Like, what's different?" And so that goals of carrying someone to death is something to avoid. I try to set expectations for palliative care consult, i.e. we're not going to just advertise DNR, DNI and think, we're going to kind of align with the family and kind of confirm confirm that they understand kind of what's happening, and that what they're getting is in alignment with their goals or with their values. But setting some expectations, I think, is fair. Okay, so part of the tool that goes along with this moral distress, like keeping your ears tuned to kind of moral distress in the wind, is kind of be prepared to reframe either your own reaction or others' reactions with kind of patient values in mind. Because I think that if people try a little bit to kind of see things from the patient's family's perspective, it helps them feel like, oh, maybe I'm not torturing this person against their will, but maybe this really does line up with their values. So in kind of, at times where there was like, you have to tell this patient about their cancer because denying that the information is deceitful. And that's not to say that when someone wants the information that you don't tell them, but in cases, for example, where the patient doesn't want to know and the family doesn't want to tell them, the kind of values kind of reframe is, how the family might see this is protecting our family member from information that we feel like is going to be harmful is our family duty. I would not be a good son if I let you kind of walk in and hit mom with the sledgehammer of the diagnosis of metastatic cancer. So kind of just helping people dip a toe in seeing things from another perspective. So that I see a lot. This idea of, oh, this is futile, like we should not do CPR because it is futile, or we should not do X, Y, or Z because it's futile. We shouldn't do antibiotics because it's futile. I hear it a lot. The reframe, or how a family might see that, is, oh my gosh, like you didn't give us the treatment in the hospital. Like, was that due to discrimination? Like, was that, you know, is there a kind of a prejudice that why we didn't get the care that someone else might have gotten? So I think that we have to be careful around this language of futility, and kind of how saying, oh, we're not doing something might be received. And is that causing more harm than the intervention itself? And I've definitely had cases where families were potentially more distressed from the fact that their loved one did not get CPR due to futility, rather than the fact that they were denied some life-saving, what they viewed as a life-saving intervention. So it's important to recognize that there might be a different perspective on that. I think we all are familiar with this, like, oh, my quality of life is not acceptable, and forcing someone to continue living with an unacceptable quality of life is kind of what cruelty means. Other folks might say cruelty is being forced to die when there are treatments that might prolong life, kind of regardless of whether that quality of life, I think, is another one of those kind of cultural kind of things where maybe it's maybe life itself is the most important thing, and there's no such thing as a quality of life, and that is also kind of at the level of the person, might not necessarily buy into that concept. So they don't get it. I think you'll hear probably in the first week kind of in palliative care consult mode, you need to talk with them. They just don't get it. I told them yesterday, like, she's not going to get better. Like, she's not getting off the vent, and they just don't get it. Like, you got to do something about that. And I think Caroline Hurd gives a really great talk about kind of what families really mean when they say they don't get it, or what's really happening with families when providers say they don't get it. But the truth is, they may understand how serious things are, but they just don't believe that doctors in their world have all of that information. Doctors don't know when God, for example, may end someone's life. And so I think, or the doctors have been, what I see all the time is the doctors have been telling me I'm going to die for the last like 2 years, and here I am. So just be prepared that people get their information not only from the doctors who are talking to them right then, but from their family, from their own lived experience, from their faith. And they use all of those things to look at the lens of look at what the doctors are saying with that lens. So just with some humility, that it's not a question of just I told them and they didn't understand. Okay, so helping people see that can sometimes take some of the pressure off the moral distress. In terms of interpreters, I wanted to kind of just hit a couple of pearls. Let's see how much time I got. Oh, I gotta rock and roll through this. So in terms of interpreters, some of the problems that I see is that we get a little too casual about using bilingual staff or family. It's really a practice to avoid, and studies have shown that even when the nurse is fluent, even when the family member is fluent, there are errors in about 50% of these interactions. So I know at Harborview, we're tracking kind of times when people have gone without using interpreters for 24 hours in the hospital when we know English isn't their first language. Like, how does that happen? And so we're really discouraging the practice of using anything other than a formal interpreter. Sometimes families are insistent and they say, we used the interpreter yesterday, it really sucked, and so we don't want to use that again. But I think like documenting that and kind of pushing a little bit, but interpreters are better than family and they're better than bilingual staff, and so be mindful of that statistic. Studies in ICU settings, and these studies are probably 15 years old at this point, but hopefully we've made some improvement. But I think when we think about interpreter sessions or end-of-life discussions involving interpreters, we're like, oh my gosh, this is going to take forever. Like everything has to be said twice. This is going to be like 2 hours out of my day. But truthfully, when timed, interpreter sessions, they last about 6 minutes less. So these goals of care, Dan's like, what? It's like they are actually shorter. Because we use fewer empathic statements. Okay, we're kind of stuck to the facts because that's what we're comfortable interpreting. Empathy is a little tougher to kind of transmit, and so just be mindful of that, and for that reason, try to be kind of explicit when you're expressing your empathy. So using interpreters better. So pre-huddling, we talked about setting up the room to minimize challenges. And so what I mean by that is you and the interpreter should sit next to each other facing the patient. So the patient isn't facing the interpreter and hearing what they have to say and turning and facing you and facing 180 degrees and hearing what you have to say and going back and forth. But when you sit down in the room, be intentional about minimizing the amount of like head whipping you are asking this person to do. So just sitting next to an interpreter kind of in front of the patient. It seems kind of basic, but we all just kind of go into the rooms and get started. So continue sending Tena Listeling for yourself. So that's kind of a greeting in Amharic, kind of how are you doing? And I'm not kind of offering that you propose that you pretend to speak a language that you don't speak or fudge it when you don't know when you're not an interpreter. What I'm saying is like have some greetings, have some social graces in another language, because I have not met a person who, when greeted in their natural language, isn't kind of appreciative. I think my French is very bad, but even the French patients I've had have been grateful when I've said something in French. So it's, like if you can learn a few greetings, or even just right before you go in, just to say hello and ask how are you, I think it goes a long way to let people know you're kind of an ally. Keeping it to 2 sentences, because the longer you go, the less accurate it gets. So having that in your mind, 2 sentences, very short. Jokes don't usually translate very well. And like I said, the 6 minutes shorter because of lack of empathic statements, just have it in your mind. I am going to really try to send this empathy and be explicit with it. And debriefing with people after the fact so that you get a chance to help them process their feelings and kind of process what did or didn't go better or didn't go well. So that's kind of some basic interpreter skills. I'm going to sprinkle in some just general communication pearls for cases like this. I think you guys have you're getting the kind of NURSE acronym for kind of responding to emotions. I think in these cases, those respect statements kind of punch above their class. Like they're really good because there's so much kind of filial obligation of the younger generation to take care of the older generation or the family unit to stick together. In many of these cases, respect statements are really meaningful where you're saying like, I really appreciate your being here and kind of looking out for your mom this way. Or your family has been here every day. I don't see that all the time. And I just want to acknowledge how special that is and how well you represent your loved one. These things, letting people know that you kind of see their family and the strength of their family goes a long way. So think about those respect statements in particular. I mentioned kind of learning a few kind of phrases. In Arabic speaking communities or Somali communities or other Muslim communities, this language of inshallah, like Lord willing, or if it's Allah's will, or alhamdulillah, like praise be to God, like we're grateful that this was God's will. I'm not pretending I'm Muslim, and I'm not, again, pretending I speak Arabic, but, a few things like this, where you acknowledge humility and acknowledge kind of another person's belief. I've never had it go badly. I've never had someone say, "Why are you using this language? It's not appropriate." It's like, I hope this happens, and I'll say, "Inshallah." We will learn God's will together. And I think that is fair game, and I don't think that's like appropriation or anything. At least I've not gotten that feedback in real time. Um, but I mentioned that as something to consider. I also see that sometimes, you know, acknowledging um, uh, ag- acknowledging kind of that we might not know what the future is, kind of acknowledging that there might be some lack of clarity, is pretty popular in medicine, to say like, we're not sure what's going to happen, or I don't know when this might be. um, and sometimes that can be kind of just real. You're kind of you're a humble doctor, but other times in other communities, when doctors say they don't know, that means they are a bad doctor. And so I think to express that uncertainty without saying I don't know is a little more effective. So I do that by speaking from my past experience. I will say, I have taken care of people where this happened, and I have taken care of people where this happened. I am an experienced provider, and you should trust me, but sometimes both of these things happen. And so I'm saying the same thing, which is, I don't know which way this is going to go, but I'm not saying I don't know. Because they'll just be like, okay, well, find me a doctor who knows, please. This is an important time. So I would consider that. I also think this is particularly helpful, for providers that might get kind of pigeonholed or stigmatized. I hear this from my residents that I work with, like kind of super smart, amazing doctors who are young, who may be female or whatever, and the family is just like, I'm going to treat you with a little less authority, or you're going to have less authority, but just like speaking from experience, like I have experience here. In my experience, this is what I've seen. So I think that can be helpful. Um, in these cases, I tend to be like, use the word expert a lot. We're going to get our experts into for nutrition, or our infection experts. People appreciate that kind of hierarchy. Avoiding language of not doing, okay? Even in transitions to comfort care, et cetera, talking about what you are doing. We're going to be turning them every 2 hours. We're going to be taking good care of their skin. We're going to be thoughtfully assessing their pain and symptoms, even when they're asleep and not talking to us, talking about what these actions are, active care more so than kind of, these are the things that will stop. For good reason, these populations feel like disenfranchised by the healthcare system. So it's really important to express non-abandonment. No matter what happens, we're going to be in your corner. I think that is a really, really an important one. Sometimes getting the family additional help with like immigration and that sort of thing. Like I've written letters to Patty Murray to kind of get help get visas and that sort of thing. It's not always helpful, but families appreciate it. So I only have a few minutes left, so I want to kind of really fly through these last couple of slides. But this patient, real life, okay, spent 7 months in the hospital. The family, super amazing, converted their garage to a room. He insulated the garage door. Daughter learned how to run the ventilator, no lie. She was trached and then discharged home, and the daughter did all of the ventilator management at home. And she had a couple of different hospitalizations over the course of 6 months, maybe 3 or 4 times when she got viral infections and that sort of thing, but got home every time. She went from being in a vegetative state to oriented, moving all her extremities. She was weaned from her ventilator eventually, and her trach closed up. Her infection, which everybody said is impossible to cure with antibiotics alone, because that's just what doctors are taught, was cured with antibiotics alone. She got to a power wheelchair and was getting to mosque with her family. Family super happy with progress. She's fully awake, oriented, and kind of gets in to see her primary care doctor via her electric wheelchair. And she and her family are really happy with kind of how things have gone. So to that I say, alhamdulillah, praise be. Like we're all grateful for that outcome. So I want to highlight another idea in that a lot of these conversations are had kind of in particularly fraught settings. Okay, the oncology office or the ICU, and in the interest of kind of getting out of those kind of gloomy situations, we went out into the community with our cultural mediators program, and I don't know if any of you have had the opportunity to work with some of these folks or in other similar programs, but it's a group of folks at Harborview who are coming from various communities, whether that's Vietnamese or Somali or Amharic-speaking Ethiopian, Latino communities, and help people navigate not only the healthcare system, but also the divide. So they work as interpreters, but they're really special in terms of coordination and kind of helping people understand more deeply kind of what they need to do, et cetera. And so there's also diabetes specific, but they come with a lot of cultural understanding for various communities. So I kind of partnered with them, went out into the community. This is us with our Amharic speaking Ethiopian cultural mediator at the Ethiopian Community Center doing a talk on advanced directives. We had a little kind of pamphlet that we brought, and we gave people a chance to ask questions. And I don't know if you can see, but this guy's got a big old smile on his face. Like this was like a really fun kind of thing. And we're talking about death, we're talking about all this stuff. It's kind of hard, but people are like well supported. They're in their community, they're with their friends, and they're making jokes, and they get some information, and it was a heck of a lot more comfortable than kind of downstream. So I would say think about these, think about outreach, think about ways, if you're seeing trends in your hospital of like, gosh, we're taking care of these communities and it's another one of these really fraught ICU conversations with this community, maybe we need to get out into the community and like talk with people when we are outnumbered. And it's not 10 doctors sitting around 3 family members. It's a doctor talking to a group of 20 people, and being approachable and being another face of palliative care elsewhere. So things I hope you will remember. We all come to the table with bias, lots of them. They are heavily influence what we do and how we think, and check in with yourself, particularly in these cases, about some of the multiple biases. Try to be sensitive to the moral distress around you and engage with it. I'm not saying that you are the cure for moral distress, but engage with it and help kind of depressurize it if you can. There's resources out there for homework like Ethnomed, which I love. And remember that palliative care is about values and values assessment, not about kind of saying something the nice way to make, it's not the Jedi mind trick. It's kind of a values assessment. And in some communities, doctors don't know when people are going to die. And this is not to say that you should always hedge, but acknowledge that might not be a concept that's appreciated or kind of felt to be true. And when you're working with interpreters, slow down. You got an extra 6 minutes, and try to empathize as much as you can. Getting out to the community, I think, is actually good for the moral distress piece too. I think if you're like, oh, this community of nurses that I'm working with are super kind of beaten down, like let's go out and have like a community information session where we get the nurses out and get them to talk about their experience and can kind of share information in both directions and give people a different experience than ICU alone on both sides. So anyway, I hope that those things will be, I'll leave you with those. You should not be shy sending me an email. I fill up a 1 minute extra so that you guys cannot ask questions. But feel free to email me a question after the fact. I'm happy to help any way I can.
Thank you so much, Jody. If you want to close your screen share just so we can all see you a little bigger and share our gratitude. Thank you so much for sharing all of your insights and thoughts and some of the research around this topic. Super valuable. The recording of this will be online. Hopefully everyone, even though we're not going to take a long time here at the end of our hour, hopefully we've got those questions that you're all familiar with in your brain of the what surprised you, what will you take forward, and what are you still noodling on? Lots to be noodling on here. We'll stick
Forever.
around for yeah, forever. Lifelong learning, yeah. Hashtag
Yeah.
lifelong learning. We'll stick around for just a moment, especially if anyone has any logistics questions. Helene, thank you so much for the recording. Otherwise, for those that need to go, thank you so much for being here. We'll look forward to connecting with you soon. We've got one more live webinar coming up on March 15th, Wednesday, on grief and loss. It's a new module for us. Oh, March 13th, Wednesday, March 13th. Great. Same bad time, same bad place. Thanks, y'all.